Few important things that we all need to understand about partner cohort B. At 5 years, 94% patients were dead in the standard therapy arm. This is a natural history of severe AS. At 5 years, 94% patients were dead. In the TAVR arm, 72% patients were dead. Okay? And then, based on the data between years 3 and 5, 66% additional patients died in the standard therapy arm, and a good 40% because they're elderly patients. They didn't die because they had AS. They could have died because of frailty and 10 other reasons. But again, the point is that you gain a median survival benefit of about 18 months, which was about a year and a half, which could mean a lot for a lot of individuals. Okay, and obviously this is absolute survival benefit. We're not talking about the quality of life and other measures, other variables that were predominantly in favor of TAVR. You have to understand that this was the first generation of the TAVR platform. Procedures were performed under general anesthesia. It was mandated that every procedure be performed under TE guidance, and usually 24 French sheaths were used with lots of vascular disasters. And as I emphasized before, be mindful of the fact that standard therapy did include BAV in about 80% of the patients. That did not seem to alter the natural history of disease. Then came the partner A, which included patients who were at high surgical risk, but could undergo surgery. And they were randomized to TAVR versus surgery. And you can see that at 3 years, really, initially, in the first 12 months, TAVR was really better in terms of cardiovascular death, as well as a composite endpoint of stroke and death. And this was sustained through 3 years. Again, this pretty much shows the same analysis. Sorry, this is partner A. And so what I wanted to point out here was that obviously the vascular complication was much higher in the TAVR arm. This is still the first generation valve. Then came partner 2, the intermediate risk. TAVR was clearly superior, although the trial was designed to be non-inferior. So it did meet the non-inferiority margin, and there was a clear-cut benefit of TAVR over SAVR that was sustained through 5 years. A very important concept that we all need to understand is that of paravalvular regurgitation. Anything above moderate or severe was directly linked to the risk of long-term mortality, such that patients who had trace or mild PVL, their mortality was about 14% at 2 years, compared to those who had moderate or severe. Their mortality was a good 20% points higher. This is absolute mortality. And then the low-risk individuals clearly showed an astounding benefit in favor of TAVR compared to surgery. Important points again, because if you've got a young patient, a relatively young patient who has severe AS, you have to understand that if you look at these numbers closely, the risk of new onset AFib was almost 40% in those who underwent surgical AVR, as opposed to 5% in a TAVR arm, and the length of hospitalization was on an average a week compared to 3 days for those who underwent TAVR. Obviously, a huge significantly better outcomes in terms of the quality of life and the time to quality of life. Again, if you look at the composite of death, stroke, or rehospitalization, that strongly favored TAVR over SAVR. Then comes the point of, we are using self-expanding valves. How do they compare to the balloon expandable valves? There have been only two randomized trials that have been done, again small. This is a large French multi-center registry, and that actually showed, although they did balancing analyses, it did show a strong trend towards a better overall profile for balloon expandable platforms. They actually demonstrated that mortality was lower, and these are all comers with balloon expandable platforms. The risk of permanent pacemaker was almost 26% with the self-expanding platforms and about 8% with the balloon expandable. And they also showed a higher risk of stroke because with the self-expanding, the device had to be captured, and the more tries you have and you rub against the aortic valve, that proportionally increases your risk of stroke. So this is a small randomized trial that compared head-to-head comparison of, again, the XT variant of the valve compared to the core valve, and the follow-up really at five years. This trial demonstrated a numerically lower mortality in the self-expanding platform compared to the balloon expandable platform. The hemodynamics of both platforms were nearly identical, but the absolute orifice area was much higher for the self-expanding platforms because of its supraannular position. So how do we reconcile all of this? So there are important anatomic characteristics that you've got to keep in mind. Unfortunately, we only have one option, so we have no option. So that's the only thing we have. So if you had a choice and cost was not an issue, what would you really look at? Now, obviously, if you've got an extensively calcified root, you really want to use a more forgiving platform like Evolut, and now very soon we're going to have a Chinese variant of that, and then the Accurate Neo2 with Boston. If you have extensive angulation of the aorta, small low coronary height, and the patient has extensive CAD, needs to be re-intervened, and the patient has a high risk for a pacemaker, then a balloon expandable valve is ideal. If you're really concerned, you've got a 400-pound lady who is 4'8", and you're really worried about patient prosthesis mismatch, then you really want to go for a supraannular platform like Evolut R. This is a very good slide, a very busy slide, but this was put together by Samir Kapadia from Cleveland Clinic, and he talks about everything that's out there in the literature that predicts the risk of a permanent pacemaker. So really from a clinical standpoint, what you really need to know is somebody has a baseline right bundle and a first-degree AV block. This patient has a good 70–80% chance that he's going to require a permanent pacemaker. Now, when we had COVID, there was a push to discharge patients the same day, and we discharged about 14 patients the same day. So the protocol we used was this rapid atrial pacing. On the way out, you pull the pacer back and put it in the right atrial appendage and pace the heart at 150 to 160. And if the patient goes into Vancomycin or a higher degree block, that means this patient has a higher risk of requiring a permanent pacemaker. It's got a great negative predictive value. So if it's negative, they don't go into a block, you can safely discharge the patient the same day. But the most important predictor really is a pre-existing right bundle block. Any kind of a block, even left bundle or first degree, increases the risk. Now with the technique that we employ routinely of using the cusp overlap view and aiming for almost 100-0 deployment at the non-coronary cusp, that risk has significantly gone lower. Obviously, if you oversize the prosthesis and you've got a lower implantation depth, that is also independently predictive of the risk of a pacemaker. So what do the guidelines tell us? I'd like you to focus on the chart right here. So if you've got someone who's less than the age of 65, is healthy otherwise, very active, that patient must get a SAVR. See, there's a 60-year-old and then there's a 60-year-old. You could have a 60-year-old who's independent, works, has a life expectancy of about 20–25 years. This patient must get a SAVR. And then you've got a 60-year-old who's diabetic, whose kidneys are frail, also has COPD. His longevity is no more than 5 years. Okay, this patient you would not send to surgery. Okay, so these are clinical guidelines, although I did share with you the results of partner 3, and one could make an argument, yeah, sure, but if you look at the granular details of partner 3 and see how many patients were actually less than the age of 60 is a very small percentage, less than 5%. So if you have someone who's really in the age group of 65 to 80, you could go both ways, and obviously above 80. Now, how do we do that in our Pakistani population? In my mind, I say if someone is above 70 and above, we must do TAVR first. Again, looking at the patient. We've done patients as young as 58, 59, and Tahir Sagir Saab can tell you his experience. I'm sure you've done a lot younger patients who were sicker with TAVR. So again, you've got to look at the patient's biological age. The other problem in our country is nobody tells you the real age. You know, we've got a 70, 80-year-old grandma who thinks she's still 38. So is she 38 or is she 78? So that's the other problem. Okay, now shifting gears to mitral repair. I'm just going to talk about not the procedural details, but the clinical evidence behind it. So again, this is now the standard of care for anything that can be repaired, and obviously patients who are not surgical candidates or are considered high risk for surgery. Just a few quick things about the device. It has a learning curve. I remember about 7-8 years ago when we did our first case, it took us almost 6 hours. And now if it's a straightforward FMR case, stick to close would be less than 30 minutes. Just like sometimes a right heart cath takes you longer than just doing a clip. So obviously the more you do, the better you get it, just like anything else. So what's the data behind that? Now I want you to know by heart these 2 clinical trials, okay? And the reason I say that will become evident to you, because if you want to understand mitral regurgitation, you must understand these trials and why they have essentially diametrically opposing results. So the first is the MITRA FR trial, and this was a randomized comparison of a patient who had severe heart failure, severe left ventricular dysfunction. They were randomized to optimal medical therapy versus mitral clip therapy. There were roughly 300 patients, 150 in each arm, and the primary endpoint really was a composite of death and hospitalization. At one year, there was no difference in this European trial. Then came the COAPT trial. So what was the COAPT trial? You had patients who had cardiomyopathy, regardless of whether ischemic or non-ischemic, EF between 20 to 50%, and your left ventricular end systolic dimension, end systolic, this is not end diastolic, end systolic dimension had to be less than 70. So you were allowed really big ventricles, okay? You had to have a moderate to severe MR, and obviously you had to be symptomatic despite guideline-directed medical therapy, and that included CRT, because you understand a large proportion of MR and LV dysfunction patients is related to a baseline left bundle and a dysynchrony. So if that was the case, patients were mandated per trial protocol to get their CRT device and reassess if they indeed had that. And patients were required to have had at least one heart failure hospitalization. These were patients where the surgical risk was high, it was above 8%, and the surgeon had to say that, no, this is not an operative candidate. And the interventional cardiologist then had to say, yes, this could be easily clipped. So you can imagine that there were a lot of patients who were screened, and a lot of them were excluded based on those patients who were clinically unstable, who had other comorbids, including COPD, other valvular disease, and anatomic exclusions, like if their baseline mitral valve area was less than 4 centimeters squared, and they had other precluding medical conditions that would compromise their longevity to less than a year. So what did this show? This showed absolute benefit in terms of not only heart failure hospitalizations, but mortality. There was a mortality benefit to patients who got a TEER. You can see that the number of patients are twice that of MITRA FR. And after 1 year, if you saw the landmark analysis, there's actually a 38% risk reduction for absolute mortality. And if you look at death, hospitalization from heart failure or other cardiovascular causes, there was a profound benefit in those who got a TEER device. So why is hospitalization important? Because understand, a patient who has heart failure hospitalization, this patient has an 80% chance of mortality at 2 years. So if you have someone with an LV dysfunction, he gets admitted once with heart failure, you know there's an 80% chance this patient would be dead in 2 years. So this is why this data is so fundamental. You know, you keep admitting these patients with heart failure in the ER. Understand, they get admitted once, you know that there's a less than 20% chance this person is going to be alive in the next 2 years. All right, so you've got to do something. It's not about just giving diuretics and sending them out. So based on this, they came up with what is called a COAPT risk score, and really the most important determinants of death or heart failure hospitalizations were CKD and pulmonary hypertension. And obviously, if you got a TEER device, you got negative points. So why do you have two trials, one European, one American, with two very opposing results? The easy answer is the American results were cooked. But there's more to this. Now, if you look at the differences, patients in COAPT were older. Patients in COAPT had more severe mitral regurgitation. Look at the mean EROA of MITRA FR was 31, whereas in COAPT it was 41. But patients in MITRA FR had more dilated left ventricles. Their left ventricular index was 135 compared to 101, but both had severe, almost identical, severe left ventricular dysfunction. So again, a degree of, if you look at the absolute mortality, it was 24% in the MITRA FR and 20% or about 19% in COAPT. And if you look at heart failure hospitalization, that was also significantly lower. So you have patients who are whose risk profile is identical, but you have two different results. So that has to be related to device therapy. So then this got people thinking, and then they decided, how do we reconcile this? If you look at patients who have severe LV dysfunction, have severe MR, then there has to be a certain concept. So if you have severe LV dysfunction and your LVs are really, really dilated, those patients, you're not sure if MR is going to work. Obviously, if they have mild, moderate MR, you're wasting a device, okay? And if you have patients who have that ideal LV size, have severe LV dysfunction and severe MR. So this led to the concept of proportionate versus disproportionate MR. So this is something you all must know in 2022 if you're practicing cardiology. Okay, so proportionate MR really is MR that is directly related to the degree of LV dysfunction. So the LV has become so dilated now, there's so much tethering and malcoaptation of leaflets that the mitral valve is acting as a pop-off valve. It is a protective mechanism to keep the patient alive, okay? So that is proportionate MR. And for such patients, really medical therapy, you know, you've got to do agents that help with reverse remodeling. And then there are patients whose MR is out of proportion. So yes, they are dilated, but they're not so dilated where the leaflets are so tethered and so malcoapted that you're going to get MR. These patients have ischemic MR, or they have dysynchrony that is causing MR. Those patients would benefit mostly from that. So understand the concept of proportionate versus disproportionate MR. Proportionate MR is the natural history of LV failure. This happens, it's a sign of a failing LV. It is prognostically important, yes, but if you close it, like I said, it's a pop-off valve. But disproportionate MR in severe LV dysfunction is a modifiable thing, and if you can treat it with mechanical therapy, the patient is going to improve. So again, proportionate MR, you've got to use your guideline-directed medical therapy. Disproportionate MR, things like CRT, tear, and mitral valve surgery would be helpful. So just real quick on, there's a new device that is FDA approved now. It's called Pascal. These are results of the Class 2D trial. I was part of this trial, and we did about 8 cases. The device is a lot more facile, much better, much more significant reduction in MR as demonstrated in the clinical trial, and then that translated into improved clinical outcomes. So then there's a third concept that I want everybody to understand, and that is the concept of atrial functional mitral regurgitation. These are patients who have long-standing atrial fibrillation. Their LVs are completely normal. Okay, they don't have primary mitral valve pathology. Their atria gets so enlarged that the mitral apparatus gets stretched on account of that, and that causes MR. All right, this has to be really distinguished from our FMR, secondary MR, that happens because of LV failure. Atrial functional MR, we don't know what the best way of treating this is. Do you put them back into sinus rhythm? Do you do atrial fibrillation ablation? We did a couple of mitral clips on them, but I will tell you, these are typically elderly old ladies with small ventricles and these gigantic atria that have severe MR. So we really don't know how to best treat these patients, but you must be aware of the concept of atrial functional MR. So in summary, for mitral regurgitation therapy, patients who are really symptomatic, and I would add to this, who have disproportionate MR and are at a high risk of surgical therapy, TEER is a very good option to prevent death and heart failure rehospitalization. And for degenerative MR, if you have patients who have, again, high surgical risk and are very symptomatic, TEER is a very good option. These are both class 2A indications. And what are anatomic characteristics that would favor TEER? You've got to have a valve area of more than 4. Really at the point where you grasp, ideal is A2P2, but we've done all iterations of it. Coaptation length has to be adequate, so you can grasp the leaflets. The depth has to be less than 11, otherwise that means they're really tethered. And most important is the size of the P2. The P2 is less than 10 millimeters, less than a centimeter, that becomes a huge problem. Or the posterior leaflet could be P3 or P1. Now coming to the last topic, and I'm 26 minutes. So somebody told me they were asked the shapes of atrial appendage on the exam, okay? So please, this is in your booklet, all right? You all love chicken wings. Understand chicken wing is the most common type. This is the one. So there are different types: chicken wing, a swan, a cauliflower, and a windsock, okay? This is how it appears. But the one that has the highest association with stroke is the swan variety. There are multiple devices. 2 of them have been FDA approved for left atrial appendage closure. This is the Prague 17 randomized trial that compared DOACs to left atrial appendage closure with Watchman, and it actually showed non-inferiority. If you look at hemorrhagic stroke, that was lower in the device arm. Overall death was lower in the device arm for undescribable reasons. And then if you look at the analyses of all the trials and going from PROTECT to PREVAIL, it does show at least a non-inferiority for left atrial appendage closures. And now the recommendation is patients really who are at a risk or who have contraindications to long-term therapy with anticoagulants must get left atrial appendage closure. And these are some NCT criteria for your review. Thank you for your time. I'm sorry I'm 3 minutes up.